No? Yes? Yes? Okay. All right. Let me just focus the screen. All right. So let's get started. Okay, so this is a 27-year-old male with a change in bowel habits and lower abdominal pain. This is actually labeled as ileum, which is an interesting location for this, but let's go on. How do I control the condenser? Oh, there. Okay, good. Okay. All right. I'm not sure how interactive. Like, are these usually pretty interactive? Okay. All right. So, first of all, so this is called ileum, 27-year-old male. And on low power, how would you describe what we see here? Anybody?
The villus architecture is preserved.
Good.
And on the lower part, you can see there are a lot of probably lymphocytes within the epithelial cells.
Very good. Yes.
And even in the sternum.
Very good. Yeah. So even on low power, from far away, you could see that there are intraepithelial lymphocytes. The villus architecture is preserved. So that gives you already a differential, right? So what causes intraepithelial lymphocytosis in the small intestine?
Any inflammation,
lymphoma, sure. Okay. What's more common? Yeah, celiac is more common. What else?
Drug
effect. That's right. So olmesartan can cause it. And also this entity. Did anyone see what this was?
There are those pear-shaped stuff.
Yeah.
On the surface, right?
Yeah, pear-shaped stuff on the surface. Right. Actually, this pattern is called falling leaves.
Mm-hmm.
So Rifat knows what this is, but anybody else? Yeah, it's Giardia. Yeah, so it's actually a very high infestation of Giardia. So Giardia, these are trophozoites. So Giardia, when they are infective, they'll be cysts. So people swallow the cysts, and then they exist and become trophozoites. And they actually like to be in the duodenum, which is why this location is kind of strange for Giardia. And I actually had Rifat double check to make sure that this wasn't duodenum. How do we know it's not duodenum? Yeah, there are no Brunner glands, right? But patients can have a Giardia infection in the ileum as well. It's just less likely. So it's more likely to happen in the duodenum. It happens in children and also in young adults, so patients in their 20s and 30s. It also has a peak during late summer and early fall. I think it's probably when people are camping, drinking water that's probably not that clean. The things that you need to know is that these bugs are often associated with intraepithelial lymphocytosis. So the main point is that intraepithelial lymphocytosis is not just specific to celiac disease. It's actually quite non-specific, and we just covered a whole bunch of entities that can cause it. So when you see this, your first instinct should not be celiac. Of course, you should think of it, but other things to look for are whether this patient might have an infection, and also just give the differential. The final thing that I always look for is plasma cells in the lamina propria. Why would I look for plasma cells in the lamina propria? What entity does not have plasma cells in the lamina propria? Anybody?
Cvid.
That's right. Cvid, you should not see plasma cells in the lamina propria. But here, actually, we see quite a few, which is normal. You can see them here. And actually, patients with Cvid tend to have intraepithelial lymphocytosis, and they also get Giardia. So that's something that should be also high on your differential. You can't just stop at Giardia. You should also look for the plasma cells to kind of get a sense of whether this could be Cvid as well. Okay. Let's see if I have anything going on with that. I think that's it. Okay. So let's move on to the next case. Any questions? Feel free to ask any questions.
So amlosartan has only intraepithelial lymphocytosis, or it also has villus atrophy?
It can cause villus atrophy. It actually can cause collagenous, like a collagenous sprue type of picture as well. So yeah, it's not just intraepithelial lymphocytosis. And the mechanism is unclear. They don't really know why. Some patients get it. Okay. So the second one, this is another case that. Okay, this is labeled, this is a 47-year-old female with diarrhea, and this is actually called small bowel. It's a bit of a faded slide. Okay, so it's a bit of a faded slide, but we can actually tell here are our Brunner glands over here. So we know we're in the duodenum. Okay. Okay. How would you describe this at low power? Okay. I'm going to have to start calling you guys. So I don't know your names, but we're going to go around the room because I want to just hear what you guys think. I don't care if you're wrong, and I kind of, just want you guys to talk it through, okay? So let's start with you. What was your name? Quinjing. Okay.
So I saw a lot of information.
Yeah.
So in the reflexive and also laminophobia.
Good.
To me, like the villa is kind of a little bit rotating and big.
Right. So you hit on a lot of the points here. So there's intraepithelial lymphocytosis. There's some expansion of the lamina propria with chronic inflammatory cells, and I think there's a couple of neutrophils in there as well. You mentioned that there's some villus blunting that's also seen. So here, what would your differential be? Celiac would be at the top of the list, right? But this is actually not a celiac patient. So what else would you think? So there are a couple things. Like we mentioned, celiac can cause intraepithelial lymphocytosis, Cvid, right? Autoimmune enteropathy, medication effect as well. And of course, when you see intraepithelial lymphocytosis and villus blunting in the duodenum, your first thought is celiac disease. Always go on higher power to look for plasma cells. Right. There's actually no plasma cells here, but it doesn't look like the lamina propria is vacant, right? It's actually full of other inflammatory cells. So if you were just going through this pretty quickly, you may not notice that there are no plasma cells here at all. So this is a case of Cvid. It looks just like celiac disease. It tends to have a little bit more active inflammation, but it doesn't necessarily have to. You can get this villus blunting, intraepithelial lymphocytosis, and there are actually no plasma cells here. And I actually have a stain. So this is, what stain would we do for plasma cells? CD138, right? So this is CD138. CD138 also stains epithelial cells, so it gives you a good internal control. And this is our duodenum. In normal duodenum, the lamina propria is full of plasma cells, really full of plasma cells. But here, there's actually none, see? It's completely clean, completely vacant, yeah. So this is really unusual for duodenum. and it's pretty much diagnostic for CVID. Okay. So what is CVID? What does it stand for?
Common variable immunodeficiency.
That's right, common variable immunodeficiency. So it's an immunodeficiency, and it's actually a wastebasket term that's a clinical diagnosis. So you need to have a decrease of IgG and IgA, and usually also IgM. So any patients with that sort of clinical decrease, they can lump them with this CVID unless there's some other defect that they've found. So because of this, it's a wastebasket term, and what's characteristic is 2/3 of them have no plasma cells, but actually 1/3 of them still have some plasma cells. So even if you had a couple plasma cells, it doesn't exclude the diagnosis, but you should always keep it in mind because that's something that they need to work on further. So they should be looking for immunoglobulins. And these patients get respiratory infections, so they'll get like strep pneumo, H flu, and in addition, they'll get GI infections. They tend to get bacterial overgrowth and Giardia. So those are very commonly seen in these patients. Mycoplasma is another one we get in the lung. Okay. So there have been some genes that have been found to be associated with CVID, but it's because it's a wastebasket term, you know, and it's not, these genes aren't things that you actually need to know, but you should know that it's a clinical diagnosis. Okay, but it's highly suggestive, especially if you have no plasma cells. There's really no other entity that would give you no plasma cells in the duodenum. Okay?
Just like clinical diagnosis with the biopsy is not necessary.
Well, this is something that they rely on us. Usually if the patients come in with diarrhea, they're kind of young adults. So sometimes they have no idea that the patient has CVID. And so what we see can really make that diagnosis for them, and so we might need to suggest that they work up the patient. But it is a clinical diagnosis. You'd be surprised though, a lot of people walk around and they seem fine, and they have this, you know, vague abdominal pain, seem like otherwise healthy adults, and we are the ones that actually make the diagnosis. So it's always important to keep that in mind. It's in the differential for celiac disease and intraepithelial disease.
Do you see this quite frequently?
At Mount Sinai, we see it quite frequently. Yeah, I see maybe a couple, maybe one every month or so, but we actually have a CVID specialist, so a lot of them come in with the diagnosis already, or they come in with a good vague immunodeficiency, and they biopsy them and they want to know, are there plasma cells there? Do you think it looks like CVID, or do you think this could be something else? Okay. So the third case, this case, this is a good case. This is kind of tricky. So this is an elderly woman with nausea, vomiting, and a mass in a small bowel. Oh wait, this is mostly dead actually. So this is the mass in the small bowel, partially necrotic. Actually, I don't even see any normal epithelium here. It's just kind of necrosis, some like a vasculitis here, and vascular necrosis. And then there are these cells here. Oops. All right. So, huh?
My name is Mallory.
Mallory. Hi. So how would you describe this, Mallory?
So, I have already seen, it's very cellular.
It is very cellular, right?
It's somewhat pleomorphic, so it looks like to be positive to cell populations.
Okay, so you're already thinking of lymphoma, right? Okay. Yeah, there are sheets of cells. They're kind of medium to large size. They are kind of pleomorphic. What about the mitotic rate?
I see mitosis.
Yeah, it's really easy to find mitoses, right? I'm not even looking around for them, and there are a bunch of them right here. Probably here as well. So it's a brisk mitotic rate, very high. There's also necrosis. There's these large, kind of vesicular-looking nuclei with nucleoli that look very prominent. It has that space that we often see in lymphoma. So this definitely looks like a lymphoma. It's a lymphoma in the small bowel. Okay. It's a large lymphoma in the small bowel. So what would your differential be here? Could be. Well, malt lymphoma is usually more bland, right? It's usually low grade. So if it was a malt lymphoma, it would be something that maybe transferred and became like a diffuse large B-cell lymphoma. You know, I think that's a possibility. It's an aggressive big lymphoma, right? Okay. So this is a very aggressive looking lymphoma in the small intestine. And I'll show you an area next to it, which I probably should have included because it's the hint. This is the hint. Okay, so this is an area right next to it. All right. Does this look normal to you guys? I'm going for a time. What do you see? It's a little detached, yeah. It's probably not the best preserved, but how did the villi look? Did they look okay?
Intraepithelial lymphocytes.
Yeah, there's intraepithelial lymphocytes here. The villi are actually fairly well preserved with our intraepithelial lymphocytes, and that gives you a hint of what this might be. So knowing that, okay, the patient has intraepithelial lymphocytes away from her lymphoma, okay, and she has this really aggressive looking large cell lymphoma, you know, somewhere in the small intestine. What's at the top of your differential here? What do you think? How would you put this story together?
Patient had celiac.
Right.
And then there is this lymphoma.
Right. What kind of?
Associated.
Yeah, enteropathy associated T-cell lymphoma. So this patient had a long history of celiac disease. Actually, it wasn't diagnosed until she had the lymphoma, but adjacent to the lymphoma, there's a hint of what might have caused it, and that's this intraepithelial lymphocytosis. So let's see. I have some special things for this one. So enteropathy associated T-cell lymphoma. It's a T-cell lymphoma, so we expect it to be CD3 positive, which it is. This is CD3, diffusely CD3 positive. All right. It's CD7 is also positive. CD7. CD30 was focal positive. Can67 was very high. Pretty much every cell that isn't already necrotic was staining, and that goes along with the mitotic rate that we saw. So there's actually two types of enteropathy associated T-cell lymphoma. They're both related to celiac disease, and one of them they call the monomorphic type, which is supposed to be positive for CD56. So we did CD56, and it was negative. So CD56 was negative. That's positive in about 90% of the monomorphic type. This is a polymorphic type. Let's see, what did I say about this? Okay, celiac disease, don't forget DQ2 or DQ8, right? It's a way to exclude celiac disease. Pretty much everyone with celiac disease has one of those alleles. So if you are negative for those alleles, you can exclude celiac disease, okay? So about 10% of patients with long-standing refractory celiac disease are going to develop this lymphoma, and it's a terrible prognosis. The 2-year survival is about 15%. It usually occurs in the proximal jejunum. Patients are often elderly because it takes a while for this to develop. What predisposes this with refractory celiac disease is you might see some populations of cells. So we don't actually usually stain our celiac disease patients for CD3 or CD8, but sometimes the clinicians will ask us to, because if they're not responding to treatment, they want to know whether the patient could have refractory disease. So what stains would we do for refractory disease? Anyone know what the phenotype for refractory celiac disease might be? So these are CD3 cells, right? They're T cells, and they tend to be CD8 positive usually. So in celiac disease, you expect those same CD3 cells to be also positive for CD8. But in refractory disease, you have CD3 positive cells that are CD8 negative. So that's a hint that you're dealing with the clonal population, and even then, they might have some T cell rearrangement already. And those patients are really hard to treat, and they're more likely to progress to enteropathy associated T cell. All right, any questions? So we'll move on to the next case. This is a 57-year-old female, right upper quadrant pain, and this is appendix. Right, so there's really little, very little recognizable appendix here.
Which one, right upper quadrant?
That's right. Yeah. No, right lower quadrant. Right lower quadrant. Yeah. So they're presenting with like an appendicitis sort of picture, right? Okay. How would you describe this appendix?
So there's a lot of scrotal expansion. It seems like empty spaces or
Okay.
low power.
Okay.
Probably mucinous.
Okay. So you're thinking mucinous. Okay. There is an expansion. It's kind of in the submucosa, where the submucosa would be, right? And let's look to see. So if you're mucinous, a mucinous lesion would be in the differential here. So what would you be thinking?
It also looks inflammatory.
It could be inflammatory, right? Let's see. This is a higher power view. I did give you guys a hint that she has HIV, right? So that's going to kind of tip you towards more of an inflammatory or infectious etiology, right? So what are these cells? What are these cells that are kind of clear and hanging out in the submucosa? What do you think? Yeah, they're histiocytes. They're actually these bubbly histiocytes. If you look on higher power, there's something inside. Yeah, there's something inside these histiocytes. Yeah. Yeah, so she has this fungal infection. So you're thinking, yeah, some sort of fungal infection, maybe histoplasma. Why histoplasma?
The size.
Right, it's right size for histoplasma, yeah. Okay, so what stain should we do? This is considered a granulomatous inflammation, right? So we have to do all of our stains for granulomas. But, so what stain? Which one?
Silver.
Oh, silver.
No.
Yeah, silver stain. We use GMS as our silver stain. And then you should also do stains for, to rule out, you know, we should do AFB, right? And addition to GMS, okay. I thought I brought the silver stain, but I have another stain that I think would be. Okay, so this is a Fontana Mason stain. And it actually stains these histoplasma beautifully. See? So histoplasma, they like to be in, or actually they get eaten up by the histiocytes, and they proliferate within the histiocytes. And they have this kind of ovoid, round sort of capsular fungi. And they happen in immune-compromised patients and also in endemic areas. They have this granulomatous inflammation. And the other fungus that likes the appendix is mucor, which would look very different, right? Semi-car would look very different from this.
Did she travel recently to Ohio, Mississippi?
I think she had traveled, but yeah, Ohio is where you get it. Right. Usually these patients who have appendicitis with Histoplasma actually have systemic infection, and she had it also in her skin and in her lungs. And the thought is that the way that it gets into the GI tract is it's coming from the lungs, right? The patient coughs it up and swallows it. It can infect then the esophagus and then all the way down the GI tract. Yeah. What stain is this? This is Fontana Maison. It's one of our, I believe it's silver stain.
Yeah, it's a silver too.
Yeah, it's a silver stain.
You use it for melanin.
Yeah. Yeah. And it picks this up as well. Okay. I think that was all. Let me see that. It's 2 to 3 micrometers. That's pretty much it. Okay, let's move on to the next one. This is a 60-year-old male with HIV and diarrhea. The colonoscopy actually looked normal for this patient. All right. This is actually fairly subtle if you aren't used to looking at colon. Any ideas?
This looks like normal mucosa examination. And you can look at normal.
Yeah.
Some picture.
Collagenous, okay. It's not the best picture or the best slide, but there might be somewhat of a prominent basement membrane, but it's not enough for
There
collagenous.
is this fuzzy thing at the top, right?
Yes, fuzzy thing at the top. Let's go on higher power. So what could this be?
Spirochetes.
Yes, it's spirochetosis. So these are Brachyspora species. They're spirochetes, so they're going to stain with both like a spirochete immunostain or like a wart and starry stain as well. They're very common in patients with HIV, also men who have sex with men. What else? This. Oftentimes they have no symptoms, but they can have some diarrhea or weight loss. And actually, this is an entity that we make. We make the diagnosis. It'll otherwise never be diagnosed. The only diagnostic way to, or the only way to make the diagnosis is on colonic biopsy, and it takes someone to actually notice it to make the diagnosis. So when you have a patient that might be immune compromised and you know that they have diarrhea and everything actually looks normal on low power, there's really very little inflammation, just go on higher power and make sure that they don't have spirochetosis. There's actually no active inflammation.
The ink is just the fuzzy.
Yeah, it looks like hair. Yeah, it's a little fuzzy and purple on low power. Right? Mucin actually doesn't look fuzzy. It looks more like floppy or like a little thicker and not like hair. And then when you go on higher power, you can kind of see, kind of looks like a buzz cut or something. The hair, it's like hair that sticks straight up. Yeah. So spirochetosis actually has a stain. If you're suspicious, you can do the stain, but you actually don't need the stain. However, it does really pick up.
This is immunostain?
Yeah, there's immunostain for spirochete. It's good for all sorts of spirochetes, actually. It works for syphilis, but it really highlights that kind of fuzzy surface, luminal spirochetosis. All right. Sit down.
Yeah, we're on 6.
Okay, so this is a 75-year-old male with anemia. 75-year-old male with anemia. And okay, So what part of the stomach are we in?
On the,
Yeah. It's why?
you see the W.
Yeah, it's not, and it's not in oxyntic mucosa. So we're either in the fundus or the body. And what's notable about this? How does it look?
It looks locally ulcerated in some of the areas, like
Yeah.
you can see some ulceration. There is not much of inflammation, but what is significant is those acellular material which is there. So this
Right. It's like refractile.
brown
Mm-hmm.
and some are refractile.
Right. So it's a refractile brown kind of a clumpy. Sorry, my arrow. I don't know how to control this arrow. There it is. Refractile brown clumpy material.
So it looks like it's probably something like iron pill.
Yeah, this is pretty much diagnostic for iron pill gastritis. So in a patient with bleeding, they might be low on iron, or they might be anemic. So they're probably taking supplemental iron, and it causes this reaction, kind of clings to the surface and causes this kind of ulceration along the surface, and a very reactive look. So yeah, it causes local ulceration. Okay. I do have a stain for it. You don't really need to stain for it, but it definitely cinches the diagnosis. You do an iron stain, and it lights up blue. You can see that here. So this is iron pill gastritis. Okay. Pretty straightforward. Let's contrast that with this case, which is a 65-year-old male with a solid organ transplant, kidney failure, GI bleed. Now they did a gastric biopsy. I forgot I left a dot here. This is kind of helpful. So we'll just take a look. So this dot is actually for this pigment down here. Any ideas of what this patient might have? It's kind of a subtle brown. It's not showing up so well on the slide, but on the projection. Okay. See how this is there's a little brown pigment here? It's actually in the parietal cells. And then there's some active inflammation next to it. There's also brown pigment in the lamina propria, or in the musculus mucosa. Here it is in the musculus mucosa. The surface looks fairly well preserved. And this is probably junctional or antral mucosa. Junction and fundus. All right. Any ideas of what this might be? He's an organ transplant patient, which is relevant. Any pardon? Graft versus host. Graft versus host, generally, we see apoptotic figures. We might see active inflammation as well, but what we look for is apoptotic figures, which are actually very low, are normally not found in the stomach. So when you do see them in that setting, then it's suggested. This happens not to be a graft versus host.
What's the Medullary?
Cevilamere. That's actually, is that what you said?
Yeah.
That's like a resin that is kind of it's more like a purpley violet color, and it's usually at the surface. So this is actually something that's within the cells. And we weren't actually sure when we first got this what this pigment was, but with the history, I thought maybe the patient might have iron overload. So we did a iron stain on the patient. It's actually positive.
Oh.
So this is called Gastric Siderosis. See how it's lighting up all these little fundic glands. So gastric siderosis. It's actually it's kind of a subtle finding, so it's often missed. But you'll see that the iron deposition is not at the surface, but actually within the cells. And this happens in iron overload syndromes It also happens in alcoholics, patients with liver failure, hemochromatosis, that sort of thing. So
it's different from that what we saw in the previous.
yeah, exactly. So it's also iron, except that the iron isn't in the form of a pill in a lumen. It's actually within the cells. Yeah, alcoholics, transfusion dependent patients, it's fairly rare. And the mechanism for gastric siderosis is not well understood because usually when you have iron overload, it tends to affect the liver and the pancreas and heart first, and it's less likely to affect the stomach. But it's something to keep in mind if you get some funny stain pigment, work it up. Let's see. So yeah, it's generally inside the cells as opposed to in the lumen. Okay. Let's see, that was, okay, now we are on 8. Case 8 is a 67-year-old male status post kidney transplant. Now he has diarrhea. And now we're in the colon. Okay. All right. Have we both? Have I called you on you already?
Yeah.
I did? Okay, I'll let you go then. Okay. All right. How would you describe this colon?
Well, the laminar profile is very busy. There's from this colon to this.
Okay, so there's some chronic changes.
There is dilation from some glands.
Yeah, there's some gland dilation. Okay. Yeah, the laminar propria is full of inflammatory cells.
Yeah, it's chronic.
Okay. So when you say it's chronic, that means you don't see neutrophils.
Yeah.
Okay. There are actually some neutrophils.
Yeah.
Yeah, there are a few. So that makes this active and maybe a little chronic. Notice that the crypts touch the basement or the muscular mucosa. So it's actually, if it's chronic, it's probably maybe the beginning of chronicity. Okay. But it looks kind of, it's very inflamed, right? In a patient with transplant, what would be in your differential? So we have some active chronic inflammation, and we know our patient is a transplant patient.
And also echo back to graft versus host disease.
Okay, graft versus host disease.
Infectious etiology.
Right, okay. Okay, so infectious etiology, pretty much top of our list. GVHD is actually not that common in patients with kidney transplants, but it can happen. It's actually bone marrow transplants that give you GVHD in the GI tract, okay? But infection, of course, is something that we need to rule out. And then there's a third etiology that can cause this sort of look, especially these withered crypts, and that would be medication effect. So kidney transplant patients are often given a drug called mycophenolate, and that actually causes a acute and chronic sort of colitis that looks a lot like, it can look like GVHD and it can look like CMV. But here, did you guys find these?
I found some CMV like included.
You did? Good. Yeah, so this is a classical CMV inclusion. But in all of our transplant patients, we do a reflex CMV because sometimes it can be very subtle and it can look a lot like GVHD or like drug medication effect. So, but here you have these kind of withered crypts with cryptitis, a lot of active chronic inflammation. So this could either be, at the top of our differential would be like a CMV infection versus in medication effect from the mycophenolate, which is what they usually are on. So I think the way that we signed this out was that there was a CMV infection, but we couldn't rule out a concomitant drug effect. So here's the CMV stain. So the way that CMV looks when it's positive is kind of blotchy. ink blots. So these are actually the positive cells, these ink blots. And they're brown, and they should stain very dark. So if you see a light pale stain or clumpy or grainy, it's probably not a positive. Here they are on the surface. There's tons of them here. And so this is a CMV in a patient that's been transplanted. It's immunosuppressed. Okay. Next is number 9. This is a 51-year-old female with abdominal pain, nausea. This is an antral mass on EGD.
So, I see that there's a lot of inflammatory cells and some follicles.
Yeah. It's very inflamed.
Yeah.
So we'll go on high power. What about these cells here? How would you describe them?
Let's say they have large vesicular nuclei,
Okay.
multiple nuclei.
Okay. They're very mitotically active, right?
Yes.
So what would your differential be here?
I guess we're thinking lymphoma
Okay. Or neuroendocrine. Neuroendocrine is a good thought for any sort of round blue cell tumor, but in this case, it's unlikely to be neuroendocrine for a couple reasons. Neuroendocrine doesn't usually have this much association with lymphoid tissue, but there's another diagnosis where we see carcinoma, and it's intimately associated with lymphoid tissue. Does anyone know?
Epithelioma-like carcinoma.
Yeah, like lymphoepithelioma-like carcinoma, otherwise known as medullary carcinoma. So it's actually a poorly differentiated carcinoma. It tends to look like this. It's actually quite subtle. If you look at it on low power, there are way more lymphocytes than there are carcinoma, right? So if you don't look up closely, you could easily misdiagnose this as a lymphoma, or even if it's small, you could misdiagnose it as like a reactive lesion, right? So in this case, this is a lymphoepithelioma-like carcinoma. In the stomach, medullary carcinomas come in 2 flavors. Okay, so they are, does anyone know? Medullary carcinoma. Two ways to get a medullary carcinoma.
One is EBV associated.
One is EBV associated, and that's just actually more than 80% of these are EBV associated carcinomas. And the other route, what's the other way you can make one?
Mismatch repair.
That's right, mismatch repair. MLH1, and it's generally MLH1 hypermethylation, not Lynch syndrome related. Okay, so MLH1 hypermethylation can cause MSI related medullary carcinoma of the stomach. The other route is EBV. So the first thing, when you see something like this and you're thinking, okay, this looks like a medullary carcinoma, you need to order EBV. So you could do EBV-ish for that. And you also need to order MSI. And that will tell you what the etiology is of this carcinoma. It's a poorly differentiated carcinoma. It kind of forms these kind of clusters and trabecula, but it actually looks quite a bit like histiocytes if you're not looking closely. But histiocytes should not have this much mitotic activity, and histiocytes have smaller nuclei and more cytoplasm. So we did EBR on this one. And, oh yeah, so this is what a positive EBR stain looks like. And notice that it's positive in the carcinoma. It's actually not positive in the lymphocytes. So it's positive in the actual carcinoma. The carcinoma component will also be positive for keratin, just like any other poorly differentiated carcinoma would be. And we also did MSI, which was stable. So, let's see. If you look at the carcinoma component, it's actually retained. Hard to tell because they look so kind of similar to these lymphocytes, right? Lymphocytes are also going to pick up some of the MSI staining. So these larger nuclei here, that's the carcinoma, and this is positive for MLH1, which means it's retained. It was also positive for PMS2. So this is an EBV associated medullary carcinoma. So these tend to happen in elderly patients, and they're actually stage for stage a better prognosis than getting a regular adenocarcinoma. I happen to bring another one. This is another medullary carcinoma. Looks a little bit different here. Actually, much more of a traditional component here, but also poorly differentiated. A lot of lymphocytes here as well. So it's poorly differentiated carcinoma with a lot of lymphocytes as well. It's much more clearly carcinoma. This one was EBV negative. So you can see the tumor cells are not picking up that stain, and it showed a loss of MLH1. And what's MLH1's partner? When you have MLH1 loss, what's the other marker that will also be lost? PMS2. MLH1 goes with PMS2. So when you have MLH1 mutation, it loses PMS2, which is its partner. So this has loss of MLH1. You notice that the lymphocytes are in between and the stromal cells are actually picking up some stain. So it's a good internal control. And PMS2 is also lost here. So this is the kind that was MSI. Okay. So medullary carcinoma, two ways to get it. More commonly, it's the EBV associated. The mechanism is unknown. Those lymphocytes are CD8 positive, and they're thought to be actually a response to the tumor. So it's actually your own body trying to kill the tumor cells, and that's why there's so many. And that's why they think it's also a better response or better prognosis, because your own body is attacking the tumor cells. All right, so we're almost done. Case 10. This is fairly straightforward. This is a sleeve gastrectomy specimen. So sleeve gastrectomy specimen. Right. Okay, I want to call him that gentleman. What's his name?
Yeah.
What's your name? Hi.
Hi.
Hey, Seth. So I don't know if you had a chance to look at the slides, but on low power, this is what this patient's sleeve gastrectomy looked like. Any ideas? Or what do you see?
Just this patient's history, just a sleeve gastrectomy.
Yeah, sleeve gastrectomy for morbid obesity.
I haven't really seen a lot of cases.
Okay, let's go on higher time. Okay, well, first of all, what part of the stomach are we in? Yeah, probably fundus or body, because we see oxyntic mucosa. Okay. And then this is actually the main pathology over here. These sleeves.
So these lymphocytes that we see?
There are lymphocytes here. What about these? Kind of pink and kind of tightly wound. Any ideas?
So some sort of granuloma?
Yeah, and these are granulomas. So this patient has granulomas. You can see the giant cells here. They're fairly tight granulomas. So what's in your differential for granulomas in the stomach? Or granulomas anywhere, right? But granulomas in the stomach, what should be on your differential?
I think of chronic inflammatory or tuberculosis. This is what comes to my mind first.
Okay, so like an infectious etiology like TB, definitely could be TB, or you said IBD, right? Like what kind of IBD gives you granulomas?
Crohn's disease.
Crohn's disease, right. Crohn's disease gives you granulomas. So it could be Crohn's disease, could be an infectious etiology like TB or Yersinia.
Could be hereditary, like chronic granulomas.
Could be chronic granulomas disease that's more likely in younger patients. What else? Sarcoid, yeah. So sarcoid, that's actually what this ends up being. And in sarcoid, the granulomas tend to be kind of in the lamina propria or deep, okay? So they're kind of deeper, there's a lot of them, they're non-necrotizing, right? If you see necrotizing granulomas, automatically you should be thinking of TB or some other infectious etiology. But because they're granulomas and we're finding them incidentally, you still have to work them out to make sure that's not an infectious etiology. This patient ends up having sarcoidosis, and they actually didn't even know about it. Yeah, so we reported that there were granulomas, and then we called the clinician to let them know, and they worked the patient up and found that they had sarcoid.
Patient was male or female?
Female.
Female.
Yes. So
African American?
pardon?
Yeah, African American.
They are, yeah, often they're usually, people with sarcoid are usually female. They can be African American, yeah. Let's see.
Usually the calcium levels are high.
Right, their calcium levels are high. Sometimes we see Schiller-Duval. Is that what they're called? No, they're called, what are those crystals called? Okay. I forget. Yeah, there's crystals. No, those are the eosinophil ones. They get a crystal, and I'll look it up and get back to you. I forget what they're called. Sarcoid is an unknown etiology, so no one knows why it happens. You get these compact kind of bland granulomas that hang out in the lamina propria, and they're usually deeper. No necrosis. Yeah, you're seeing it likes to be in the colon, but if you see granulomas there, it should also be into that. Last case, which is, in this case is kind of challenging for the pathologist. This is a case that's harder for the pathologist than it is for the endoscopist. So it's something that the endoscopist sees, and then we need to confirm, but it's much harder for us to make the diagnosis. So this is a 28-year-old male with fatigue, weight loss, adynophagia, found to have candida, esophagitis, and also a lesion in the stomach.
Was he tested for HIV?
That's a good question, right? Like, what are you thinking?
I mean, that's definitely pathognomonic for an HIV patient. Esophageal candidiasis.
Right. So he's quite immune compromised. So now you know he's immune compromised. Maybe he has HIV, and he has this sort of finding in his stomach, and the endoscopist tells you that they biopsied a lesion. Okay. So it's tricky for us, right? Because we just see a very inflamed stomach with a slight hint of maybe an expansion in the lamina propria a little bit. It looks like a reactive gastropathy, and it's really inflamed. But actually, this is the lesion. See this? These spindle cells? Yeah, it's a Kaposi sarcoma. So on endoscopies, this looks like a plaque or a raised lesion, and it's very purple and hemorrhagic. On histology, it's a lot more subtle. So you'll look around and you'll see a very reactive, inflamed-looking stomach, and look at the lamina propria. It's these spindle cells. Yeah? Sure. Okay. It's very subtle. Here.
Wow.
Yeah, exactly. So if our clinician had not told us, that they saw a lesion, it would be really hard for us to make this diagnosis. We might miss it. But you should always keep it in mind. If they see a lesion and you don't see it, you should wonder why. Why? What am I not seeing? Is it because the lesion's submucosal and they're not getting deep enough, or did they miss the lesion? make sure you go back to their report and see what they saw. And on their report, if they see it's like, they would describe it as this like purple raised lesion, you know, really you should be doing a stain for, what stain do we do?
HHV8.
HHV8. CD34 would also be positive, but HHV8 is specific, right? So that would be positive. So if I have that stain. I'm pretty sure I have the same. Give me 1 second. Aha, here it is. So this is HHV8, human herpes virus 8. And look at how it lights up all of these cells. So here it is. This is the lesion. So they, you know, if you were calling the clinician here and saying, I don't really see a lesion, they would probably reply with, no, I definitely gave you some lesion. You know, we biopsied the lesion multiple times because this is what it looks like.
Can you see that?
Yeah. So, yeah, it's much more obvious. This is the same exact case, but it's much more obvious on the immunostain.
Yeah, the other one in that first area, I noticed a subtle increase in the vessels. But
Right. It's a spindled lesion with, sometimes you see, yeah, it's like a vascular lesion and spindled, but it can be very, very subtle. It can just look like, almost like a reactive or like ulceration that's healing, you know, like fibroblast. So it can be very subtle. All right, so that was my last case. Oh, almost perfectly on time. Do you guys have any questions?
oh, yes, on the info, the computer like to see what the easy readers generally like. Which one has better prognosis?
That's a good question. Well, MSI-related tumors just tend to have a better prognosis